So thank you so much for this presentation. It was really insightful. If there's something that I like, well, I'm a technologist, right? I'm an engineer, and we need the help of all of these studies and all of these people to really understand what to do next, right? Because what they say is that technology is that thing that doesn't quite work yet. So we need to understand what doesn't work to work on it, right? So, and I would like to invite the next speaker, Veronica Rotemberg, medical doctor and PhD of the Memorial Sloan Kettering Center, and also leading the efforts of the Artificial Intelligence Working Group of the ISIC Consortium. And she has done a lot of work in the validation of artificial intelligence and understanding how we can apply artificial intelligence in the clinical practice. So thank you so much for being here.
Thank you so much for having me. Today, I am going to talk a little bit about some of the studies that are out there, and I know this is a group that's really excited about studies, and I want us all to challenge ourselves to do like really great studies that we can replicate and make better and make the world better for our patients. So I'm going to go through that a little bit. I have a couple of disclosures. I'm also on the AAD, Augmented Intelligence Committee, and the Telederm Committee for the AAD. And I consult for Inhabit Brands, but it's not relevant. So today I'm going to talk about like what is this potential for augmented intelligence? How do we design compelling validation studies? If we don't design validation studies that are really high quality, what are the dangers? And we'll talk about the potential pitfalls in diagnostic accuracy and a couple other use cases that have been touched on earlier today actually as well. So what did we know, until 2020? We had a lot of early AI studies. They could probably look at a handful of diagnoses, and accuracy almost always retrospectively tested on a convenience sample. So, images that we could lay our hands on. And usually dermatologists were evaluated head-to-head against AI or with AI on static images. So it wasn't realistic to what we usually do in practice outside of teledermatology. And since 2018, we've seen studies that showed that the potential for human AI collaborations of augmented intelligence has been very well established, especially for less experienced dermatologists. Let's see if I can use a pointer. I'm going to try. So if we look at the plot on the right, let's see if I can do this one. Oh, I'll use the arrow. What a great idea. Thanks, Trilo. I'm an AI researcher. All I do is technology, but anyway. We can see here on the right, experienced dermatologists did not derive a big accuracy benefit with AI intervention, whereas dermatologists with less than 1 year of experience, you can see their accuracy went up. And that's what we see propagated in lots of other studies, which we'll also talk about. So I really want to highlight this study because I think we have so much to learn from it. It's a prospective, randomized control trial of artificial intelligence in a teledermatology type setting. And I really want to go through what they found, what we can learn from it, what we can do better, and really push us to think about doing randomized trials, doing prospective trials in intended use settings to really learn, like, what does this technology, what can it do for us? And if we don't do trials like that, what are the risks that we have? So we have our first randomized controlled trial. It's a gold standard for a diagnostic intervention. They did consecutive cases. That's very important so that it's not a convenience sample. They compared it to standard of care. Model derm is not publicly available in terms of the code, but it is publicly evaluable. So you do have the ability to test your own images, your own intuition against the algorithm that they used. And they did a subgroup analysis on biopsied lesions. So what they found is very similar to what we saw before, which is that trainees improved significantly their accuracy after augmentation, and attending dermatologists not as much. And we're going to go through this a little bit as well. So this is the before and after. You can see the AI versus unaided. Overall, the top 3 accuracy was significantly improved. The non-dermatology trainees here for the top 3 accuracy had the absolute most improvement, and there really wasn't that much improvement for dermatologists trainees. And you see the same on the right-hand column. So really, and we've talked about this all day, there's a huge potential for people who do not have dermatology training to have significant augmentation by artificial intelligence algorithms. Here are some of the other takeaways. So we do have a risk when we have all wrong answers from the artificial intelligence. All of a sudden, the non-derm trainees are going to become even more wrong than they were before because they don't have the training to assess, is this algorithm correct or not correct? And so this is really important for us to think about what are the fallbacks in circumstances in which we are trying to augment the performance of non-dermatologists, and then we have wrong answers. There were also 4 cases of malignancy. 3 of them were basal cell carcinomas. We've seen studies today that don't include those as malignancies, for which trainees had initially included a malignant condition, so that would have led to a biopsy, but then it was ruled out in the final top 3 with the AI algorithm. And again, we talked about the non-dermatology trainees really received the most augmentation. We've also seen some other kind of use cases. Acne severity grading is a perfect example. Some people have discussed that earlier today. The one thing I want to emphasize here is that we don't have any prospective trials of this type of research, and so we really can't assess whether this would work in our settings at this point. And we talked about another study that Dr. Ketterpal is doing looking at improving telemedicine photo quality. And I want to go through this one, and I think the biggest takeaway, and Dr. Ketterpal mentioned this explicitly, is we cannot compare algorithms that try to do the same thing against each other unless we hold these studies to a higher standard. And that includes understanding better what the training distribution of the data is so that we know, is that patient population similar to our patient population? Also, making sure the algorithms are valuable. There are, of course, corporate needs in at least technologies that are developed by corporations to not give, the source code, but you do have to be able to evaluate whether these algorithms will work in your clinic. So that means, you have to test a sample in your clinic and know whether that's going to work. And then, you need a little bit more transparency, and we'll talk a little bit about how they did their study. So they did do a prospective study, and the idea was blurry photos are a big problem in telemedicine. I think we've belabored this point to death today, but it is still true. I was very impressed with some of the clinics that have less than 5% blurry photo rate. That is not what I see in my clinic. So I'm very proud of those of you who are doing patient education. In the Stanford study, they graded the photos from 0 to 4, where 0 was a perfect photo. And they were able to see a statistically significant improvement in the photos that initially were a 3 or a 4 or even a 2 when they provided feedback to the patients using their automated algorithm. The one thing I wanted to talk about is this was a prospective study, so it was great, but it wasn't a randomized trial, and it was a simulated pilot study. So it was actually just patients using cell phones in their clinic. And so I wouldn't call it a prospective study in its intended use setting. And I'm not saying these studies are bad. These studies are great. That's why we're talking about them today. But I want to push us to challenge ourselves even more so that when we come to these meetings, we can actually take home the algorithms and the tools that we're developing and say, okay, these are the steps that I need to do to actually get it into my clinic. And right now we can't do that because we don't have any of the test data that was used for any of these studies, and we don't have any information to say, how is this going to actually work in my house? So that's a little bit of what I have to say about that. I'm really excited about what everyone is working on, and I'm excited to push us to think more about how we can do these studies together. The current state of artificial intelligence in the US is that there are no FDA-approved applications at this point. One of the big things that we have going on for us is that skin lesion analyzers, at least for malignancy detection, are considered class 3 by the FDA. So that's going to require a very high level of evidence for approval. Some of the other types of products that we've discussed today might not need any FDA approval if they are for example, image quality assessment. But so far we don't have anything that we can use on the market. For static classification tasks, we talked about this a little bit. AI versus dermatologists on static tasks has outperformed us since 2017. And yet we still don't have anything that we could use or we can recommend to our primary care colleagues. And that's where this question about the quality of the studies that we do in the coming years is going to be so important, especially for non-dermatologists. We talked a lot this morning about diverse training and benchmark data sets so that, as we talked about, we're speaking the same language when we say, we have two models that are doing the same thing. And so I do have a slight conflict, which is, as Mark pointed out, I run the AI task force for the International Skin Imaging Collaboration. You do not have to use the ISIC repository for your images, but you can. And you can also use any other repository out there, but I do want to encourage you to design your studies so that the images can be used by other people in the future. That's going to be one of the biggest things that you contribute to the world, in addition to your model that you're validating. And this is just an example of what we've done. We have over 70,000 public images and close to 250,000 images that we're trying to undergo QA review. As we've discussed, it's a very manual process to get images to be able to be publicly available, and so we're working on it. And that's really all I have to talk about. I wanted this to be the subject for a lot of discussion. I want us to all work together and come up with really fun projects to do in the next 5 years. And so let's talk soon.
Thank you so much, Dr. Rotemberg. I think it's very important, everything that you covered regarding also, of course, the application of AI in real clinical practice. That is what we have to do now, right? We have been working all these years in developing algorithms. We need benchmarks for these algorithms, really to evaluate these algorithms and really compare them. It is really not useful if everyone is comparing their algorithms in their private sets of data, because we cannot compare what is the performance of all of these algorithms, and I think that ISIC is doing an amazing work there. And also, I would like to say also about your clear derm publication also. It's very important that not only we evaluate these algorithms in a standardized way, but we also find the way also to evaluate the data sets where we train these algorithms, how do we apply these algorithms in the clinical practice. So I also recommend the clear derm paper of Dr. Rotemberg.